Hello and welcome to my channel. We'll continue our talk about the pelvic walls. Today we'll be discussing the muscles of the pelvic wall. So let's begin. The muscles of the pelvic walls are the pelvic diaphragm. They form the pelvic diaphragm, and against the diaphragm that separates the thorax from the abdomen, if they contract it together, they form a ball of high pressure that supports the vertebral column. We see that evident in weightlifters. The grunt that occurs after or during the weightlifting. This is because of contracting of both diaphragms and forming a ball of high pressure inside the abdomen that supports the vertebral column, and it gives the muscles of the back a chance to, instead of fully supporting the vertebral column, and it will be directed to lifting the weight. And of course, in any condition, if there is increase in intra-abdominal pressure, right, like labor, like micturition, defecation, anything associated with increased intra-abdominal pressure, like vomiting or cough. So this is the main function of the diaphragms. Now we'll be discussing the pelvic diaphragm. It's subdivided into a mobile part, the levator ani muscle, and a fixed part, the coccygeus or ischio-coccygeus muscle. It's a rudimentary muscle. The levator ani muscle, the one you see here, attaches anterior to the back of pubis and lateral to the symphysis pubis. Posterior attaches to the ischial spines, and in between to the white line. Remember the white line on the obturator internus fascia, the one you see here, the white line, the thickening in the fascia that gives origin to the muscles. So in between attaches to the white line of obturator fascia. The anterior fibers sling around the prostate to form the levator prostatae muscle in the males and sphincter vaginae muscle in the female. This is formed by the anterior part of the levator ani muscle. Now, the intermediate fibers sling around the rectoanal junction, pulling it forwards at an angle at the rectoanal junction. This is called the puborectalis. It's very important in continence, in control of defecation. And the posterior fibers of the muscle mingle with the deep part of the external anal sphincter. The most posterior fibers to the coccyx and the anococcygeal ligament. Anococcygeal ligament extends between the coccyx and the anal canal, and it's the meeting of the muscles of both sides in a fibromuscular collection of tissues in the midline, in the middle, like the perineal body. Now, the muscle, the levator ani, is subdivided into pubococcygeus part and iliococcygeus part. This is the pubococcygeus part, as you can see here. See these two parts on either side. It arises from the back of the pubis and the anterior half of the white line, and to front of coccyx and the sacrococcygeal ligaments, where they meet where it meets the other pubococcygeus part. The iliococcygeus is at a lower level of the pubococcygeus. It supports it from beneath, and it's posterior to it as well, arises from the posterior half of the white line and the ischial spine to the anococcygeal ligament, the white fibers you see here in the middle. In tailed animals, the pubococcygeus brings the tail between the limbs, pulls it forwards, and the iliococcygeus for tail wagging. Of course, we don't have these functions. The relations of the levator ani Superior, of course, the viscera inside the pelvis, like the urinary bladder, like prostate and the uterus, the rectum, and of course the peritoneum that covers all, separated from it by the superior fascia of the pelvic diaphragm. There is a layer of connective tissue, fascia, above the pelvic diaphragm. It's the superior fascia of pelvic diaphragm. And below the pelvic diaphragm, it's the inferior fascia of pelvic diaphragm. Of course, the superior fascia of pelvic diaphragm separates the levator ani from all the viscera inside the pelvis. Now, inferior separated by the inferior fascia from the ischiorectal or ischioanal fossa on each side. We will study this in the perineum. The posterior border separated from coccygeus muscle by an areolar tissue. Potential space filled with areal tissue. Medial border separated by the viscera in the middle, visceral outlets like the vagina and the urethra and the anorectum. They all, of course, separate the medial borders of the levator ani. These are the relations of the levator ani. The nerve supply is by S4 and perineal branch of the inferior rectal of pudendal nerve. This arises in the ischiorectal fossa, the inferior rectal, and it gives a branch to supply the levator ani muscle. The action of the levator ani constricts the vagina, the rectum, for continence, for control of defecation, and by pulling on the anorectum, protects the pelvic viscera from sudden increase in pressure, and also functions in defecation and labor, of course. This is the levator ani, the mobile part. The fixed part is the ischio-coccygeus, or the coccygeus muscle. Simply, it's the ventral part of the sacrospinous ligament, and may be absent. In 40% of people, it's absent. And it arises from the attachments of the sacrospinous ligament from the ischial spine to the base of the coccyx and S5. And it pulls the coccyx forwards during defecation and parturition. But of course, it's very neglected, very limited action because it's a ventral surface of a ligament. So very minimal action or movement. It's a rudimentary muscle. The nerve supply is by S4 and 5. If there is injury to the levator ani after a prolonged or complicated labor, for example, this leads to prolapse. Prolapse means the uterus descends, takes with it. Of course, it descends inside the vagina. And maybe at a later stage that protrudes out of the body and inverts the vagina in it. This is a very advanced stage, but it may take with it, or most probably takes with it, part of the wall of the rectum as a rectocele, or the urinary bladder as a vesicocele. So this leads to problems in control of defecation or micturition. And remember that the prolapse because of the injured levator ani muscle. The piriformis muscle, it's on the back, on the sacrum, on the middle three sacral pieces, separated by the bones, but arises from the bones between the sacral foramina. Of course, the nerves from the sacral foramina, once they arise from or exit the foramina, they find themselves direct anterior relation to the piriformis, even before the fascia covers the piriformis. So they are behind the fascia. It takes from the slips between the sacral foramina. It takes from the iliac bone near the posterior inferior spine as it exits, and the sacroiliac ligament. Now exits through the greater, the piriformis, exits through the greater sciatic foramen and inserts by a round tendon in the tip of the greater trochanter of femur. This leads to abduction and lateral rotation at the hip joint. It may fuse with the tendon of obturator internus. So this is the piriformis. The relations inside the pelvis, anterior relations, of course, I told you the sacral plexus, then the fascia, and the branches of internal iliac vessels and the rectum. It descends on the sacrum, of course, and takes the curvature of the sacrum. Posterior, it's related to the middle three sacral pieces. This is inside the pelvis. Outside the pelvis, it's a different story. The piriformis is a key muscle in identifying the structures emerging from the greater sciatic foramen. Anterior to the muscle is the hip joint. Posterior to the muscle is the gluteus maximus. The gluteus maximus, major gluteal muscle at the gluteal region. The upper border is related to the gluteus medius, separated by the superior gluteal nerve and vessels. So superior gluteal nerve and vessels are the only structures emerging from the greater sciatic foramen above piriformis. All the rest are below piriformis. Below, it's related to the superior gemellus muscle. You see it here. This is the superior gemellus, this is the obturator internus, and this is the inferior gemellus. Separated from the muscle by inferior gluteal nerve and vessels, internal pudendal vessels, pudendal nerve, sciatic nerve, posterior femoral cutaneous nerve. Lots of structures emerging from the greater sciatic foramen, but remember, the only structures above the piriformis are the superior gluteal nerve and vessels. The nerve supply is L5, S1 and 2. It's called direct muscular branches, nerve to piriformis. The action is abduction and lateral rotation at the hip joint. This is the piriformis as you can see it here. We will get to it, to the structures passing through the greater sciatic foramen in the gluteal region in the lower limb. It's not our subject now. Obturator internus muscle, on the other hand, see, all this is the obturator internus. This is the inside of the pelvis, the right pelvis, looking from the left side. It takes from the obturator membrane, it takes from the bone around the obturator membrane, margins of the obturator foramen, the pubic and ischial rami, and periosteum, as you can see here, between the greater sciatic foramen and the obturator foramen, this area. All this is the obturator internus muscle. It's a big muscle, but from the inside of the pelvis. It forms tendinous bands as it emerges from the lesser sciatic foramen. As you can see, this is the sacrospinous ligament here, lesser sciatic foramen. It curves lateral on its way to the greater trochanter, and the tendinous tendinous parts of the muscle, the ventral part of the muscle that forms the tendons, they groove the bone. You will see the grooves on the hip bone in the lesser sciatic foramen. It curves lateral and inserts at the greater trochanter of the femur, anterosuperior to the trochanteric fossa. Now it has its own fascia. We discussed the obturator internus fascia and how the fascia forms the white line and how it forms the Alcock's canal present at this level. The fascia arches over the inferior rectal internal pudendal vessels and the pudendal nerve. Now, relations in the pelvis, laterally is the lateral pelvic wall, medially is the obturator fascia that covers it with the pudendal canal and the levator ani muscle that descends in this direction, taking from the white line of the obturator internus muscle. Outside the pelvis, anteriorly related to the hip joint, separated from it by a bursa. This is the tendon of obturator internus. Fuses with the tendon, the superior and inferior gemmelli, and nerve supply of the muscle is by the nerve to obturator internus from L5S1. By the way, doctors, the root values may differ. It differs between books, so stick to the source you're studying from and stick to those root levels in this text. Okay, so don't go by don't go 100% by these root values, because different opinions between different authors of anatomy books. But this is what's in Gray's Anatomy. The gemelli superior and inferior, the superior gemellus from the ischial spine, the inferior gemellus from the ischial tuberosity, they go laterally and fuse with the tendon of the obturator internus muscle, with the action the same as obturator internus, abduction and lateral rotation at the hip joint. But of course, they are accessory muscles. They are not essential muscles to exert this action on such, a big joint like the hip joint. The nerve supply of the gemelli, the superior gemellus together with the obturator internus, the inferior gemellus with the quadratus femoris. The superior gemellus takes with nerve to obturator internus, L5S1-2, and the inferior gemellus by the nerve to quadratus femoris, which is the most anterior structure descending on the back of the hip joint. It's of L4 and 5S1. Okay. The pelvic peritoneum. Now, after we're done with the pelvic walls, let's line them by peritoneum. The vertical disposition and horizontal disposition of peritoneum. The vertical disposition of peritoneum in males, peritoneum covers the sigmoid and the rectum, and then reflected on the back of the urinary bladder, the upper part of the surface of the urinary bladder, together with the upper parts of the seminal vesicles, and then covers the superior surface of the urinary bladder, and then reflects on the anterior abdominal wall, raising the median umbilical fold by the urachus. This is the how the peritoneum behaves in males. The rectovesical pouch, don't forget that, and we'll see that in a sagittal section later. This is the vertical disposition in males. The vertical disposition in females, of course, the uterus came between the rectum and the urinary bladder. So this is the urinary bladder, this is the uterus, this is the rectum here. So the rectum will be reflected as a rectouterine pouch of Douglas, and then covers the back of the uterus, fundus of the uterus, then the anterior surface of the uterus, and then reflected on the superior surface of the urinary bladder. It does not cover the upper part of the posterior surface, only beginning with the superior surface, because the uterus took much of the space. This is called the uterovesical pouch, then reflected the same as in males on the anterior abdominal wall, raised into folds by structures underneath. This is the vertical disposition in females. You see this sagittal sections, how the peritoneum is reflected from the junction of the middle and lower thirds of the rectum, either in males or in females. Here on females, this is the rectovesical pouch. C covers the upper part of the vagina, the superior fornix of the vagina. Remember this, the peritoneum. And for example, in digital vaginal examination, if you introduce the finger in the posterior or superior fornix and there's pain with that maneuver, this may be a sign of endometriosis, a case in gynecology in which there's mucosal tissue or uterine mucosal tissue outside the uterus in certain areas in the pelvis, and it may be tender on digital vaginal examination. Or anything like tumor of the ovary, for example, if it's advanced, it can be felt in the rectovesical pouch of Douglas. Now covers the uterus, the fundus of uterus, and then reflected on the superior surface of the bladder as the uterovesical pouch, and then on the anterior abdominal wall. So the posterior surface of the urinary bladder, and we will get to that with the urinary bladder, is not covered by peritoneum as it does in males. See that? How it's reflected directly on the urinary bladder? See, it covers the upper part of the posterior surface, covers the upper parts of the seminal vesicles. This is very important because aggressive digital rectal examination in case of seminal vesicle abscess, for example, the peritoneum will be involved in this abscess, and if pressure on the seminal vesicle, this will release pus in the peritoneum. This will precipitate to peritonitis. This is a dangerous case. The fold between the rectum and the urinary bladder was extending down, but it united together to form the septum between the prostate and urinary bladder and the rectum. See how it covers the posterior surface, upper part, how it covers all of the superior surface, and then reflects on the anterior abdominal wall. This is the vertical disposition of peritoneum in males and females. Now the horizontal disposition means on a horizontal plane. There's the sigmoid colon, the paravesical and pararectal fossa here and fossa there on the other side of the rectum, fossa on each side of the urinary bladders, the paravesical fossae, and folds of peritoneum that extends from the border of the urinary bladder back to the sacrum as the sacrogenital folds. Sacrogenital folds. Okay, it's the same in the females, but the uterus in between, like you can see it here. See in this plate the paravesical fossae. I brought you this plate to show you the paravesical fossae and the transverse vesical fossa, transverse vesical fold. Actually, this gives a lax in the peritoneum for the filling and emptying of the urinary bladder. So the peritoneum is folded on the urinary bladder to allow for the distension of the urinary bladder during its filling. The horizontal disposition in females, the most prominent, of course, is the broad ligament of the uterus. As you can see here, all this is the broad ligament. This is the tube of the uterus. This is the round ligament of the uterus. All this is the broad ligament of the uterus, and we will study it in details, of course, with the female internal sex organs. I hope you got the maximum benefit from this lecture, and thank you very much for watching.